today for the adverse effects management of antidepressants with Dr. Markian Pazuniak.
Thank you for the warm welcome, Mindy. Um, so, you know, SSRIs are some of the most commonly prescribed medications, um, but there are common side effects and then more rare ones. But if you prescribe enough SSRIs, then you're more likely to encounter one of the more rare side effects. These are the most common medication side effects to SSRIs, with the SSRIs being Celexa or citalopram, Lexapro or escitalopram. Those two are related. Paroxetine or Paxil, fluoxetine or Prozac, Zoloft or sertraline, and Luvox or fluvoxamine. So those are some of the more common ones that we'll be working with. And these common side effects are common amongst all of them. Now, the rates of some of them, like nausea, vomiting, diarrhea, can differ. For example, sertraline is more likely to have nausea, vomiting, and diarrhea on average than the other SSRIs, but these are common class effects. These are some of the less common side effects that we'll see, and most of these are the rate prevalences less than 10%. So these are something where you don't expect to see a lot of, but when patients start saying, hey, I'm yawning a lot more since I started citalopram, or I'm yawning more since I've had started Prozac, it could be related to the medication, and it's not something to dismiss outright. So some of the ones that can happen, these are all rates of less than 10%. Yawning, tremors or just fingertip motions, vivid dreams, dry mouth, headaches, sweating, and just lack of emotion. Even though these medications can sometimes are designed to help with depression, a lot of times you could just get emotional blunting where they feel numb, they're not as interested in other topics, or they're just seemingly not as motivated. And these are some of the rare side effects, especially if you're working on or do rotations through the inpatient units, or you have someone with a lot of other medications on board or a lot of other medical complications. These are some things you need to keep in mind. One, rarely, this is more or less than 1 out of 100 in terms of prevalence. Orthostatic hypotension, they get dizzy when they stand up. You can get jaw clenching or abnormal jaw movements. That's rare, but I actually did get a consult from a PCP about it. So if you see someone coming in saying that, their jaw starts tremoring or moving differently, then and they have any dose of fluoxetine or sertraline on board, that's something to consider. Liver injury, excessive bleeding is coming up a lot in pediatrics. So people that have a lot of bruising or they've had a lot of nosebleeds and they are going to the ear, nose, and throat doctor for concern of epistaxis, and they have an SSRI on board, it's important to rule out that the SSRI is contributing to the bleeding. Hyponatremia, low sodium can happen. Serotonin syndrome is can happen when there's a lot of polypharmacy, and it is a medical emergency. So sometimes when people have headaches, they get prescribed a triptan or another medication that has serotonergic activity. If you have too many um, medications on board that increase serotonin, you can get flushing, diarrhea, sweats, abnormal vital signs, and that is something that's very rare, usually in conjunction with other medications, but a lot of times it does warrant a recommendation to go to the emergency room. And the last one is something that is most notable. It got a lot of press, but there's an increased risk of suicidality. Now, SSRIs help with suicide completion. Population data suggests that the rate of suicide goes down with SSRIs, but what it does is it kind of uncovers underlying suicidal thoughts or behaviors. So these are actions such as cutting. These are actions such as expressing suicidal thoughts. So there is a little bit of a distinguishing what's kind of deep down inside that they're now sharing versus protection against suicide. So does this SI go away after? So they're most likely to happen in the first month, either after you start the medication or a dose change, or when you decrease it. It does generally go away over time, but it's not over 2 to 3 weeks. It's over a period of months. And that's because it helps the underlying depression and anxiety. It doesn't go away as quickly as, let's say, the nausea, because nausea is more related to the serotonin. That's more likely to um, be completed in 3 to 5 days. If it's more than that, then it's worth readjusting the dose. But a lot of times, if the suicidality is severe, it's more than just a fleeting thought. A lot of times, we recommend to just go back down on the dose or discontinue the medication if you're starting it at a low dose. So a lot of times, if you do develop suicidal thoughts that's new and that's more than what was there at baseline before you took the medication, a lot of times we recommend, and just in general, the guidelines are to discontinue the medication and try a different SSRI. So another thing that's very important to note, and it's more common in younger kids, is behavioral activation is something that's unique to kids, and this is becoming more agitated, increase in movement, so it looks like they have ADHD, and just general restlessness and pacing. And it's 2 to 3 times more common in kids than in adults. And this is just some of the statistics that show how prevalent behavioral activation is in younger kids, and also kids younger than 7 or 8 are more likely to develop side effects. So when we start prescribing SSRIs younger than the age of 7, a lot of times the risks of the medications outweigh the benefits. So there are some times where an SSRI is indicated for, let's say, anxiety, but some of the risk factors increase. This is just from a study that's mentioned here in the bottom right that shows how, even compared to teenagers, the rate of activation is much higher than placebo when compared to placebo. But for tiredness and fatigue, SSRIs are more likely to induce that side effect of tiredness in the teenage population when compared to kids. So a lot of teenagers do experience sexual side effects to SSRIs. This includes delayed ejaculation, decreased sexual interest, and a lot of teenagers will stop the medication because of this. But it's important to specifically ask about this, especially when they're discontinuing the medication, because kids will never volunteer this information. It's going to be more related um, to something that they may not even have known that it was a side effect of it. So a lot of it has to deal with the alpha-2 blockade and agonist activity at the serotonin 5-HT2 and 5-HT3 receptor. To reduce this, the sexual side effects is dose dependent. You can switch to another SSRI, or you can add to another class or switch to another class of medications that's less likely to cause sexual side effects, like mirtazapine, Wellbutrin, or Buspar. Wellbutrin is especially helpful for depression that has low energy, and Buspar is more likely to be helpful for anxiety. So when I mention when we switch to another SSRI, it's going to be less likely to be effective for reducing the side effects, the sexual side effects, than if you switched it to Remeron, Wellbutrin, or Buspar, because those three don't have that same serotonergic profile of SSRIs. So we first recommend that if it's possible, reduce the dose, possibly switch to another SSRI because it's more likely to be effective for the mental health conditions. But if that's not a possibility, there's other classes of antidepressants or anxiety medications that could be effective. Now, if those three things are not helpful, there's the last option of possibly adding an adjunct medication. You can add Wellbutrin or buspirone or cyproheptadine to the medication regimen, which would help reduce the sexual side effects of it. And go ahead. Oh, and sometimes people can add buspirone if it's helpful for depression, but you still need help with anxiety. Or you can add Wellbutrin where the anxiety is helped, but you still need some help with depression. So you can do two medications. In general, I'll try to recommend a limited amount of medications, but sometimes in rare situations, it's helpful to have two. And cyproheptadine, on a side note, is very helpful for sleep, and it's also helpful for appetite stimulation, especially those who are on stimulants and have trouble with appetite suppression. Now we're going to go into how to reduce the GI side effects. This is nausea, diarrhea, vomiting, even constipation. So it's hard to tell which SSRI is more likely to induce constipation or which one's likely to cause diarrhea. Most of them, as I said before, resolve by the 7th day, and even day 3 or 5, it should start to decrease. And if it's not resolved or decreasing by the 7th day or fully resolving by 2 weeks, then it's more likely to persist from that point. So at that point, if they're having diarrhea or acid reflux or vomiting at week 3, it's very unlikely for it to improve from that point. It does require some type of dose adjustment. Kids often and teenagers often need a lower starting dose and taking it slowly. So, for example, if you were to start an adult on Prozac 20, sometimes 10 milligrams in a teenager and a 5 milligram in kids younger than 12 could be helpful. For Lexapro, starting 2.5 milligrams can be helpful. Taking it with meals or right after meals helps with the absorption, so it's not as much as a surge in serotonin. And splitting up the dose to 2 or 3 times daily can be helpful, especially with Zoloft. So you're not getting that sudden surge of serotonin. It doesn't impact its efficacy for depression or anxiety, whether you take it once a day or split it up. It's mostly split up to reduce the gastrointestinal side effects. So some of the ones that have the highest rates of gastrointestinal side effects, I mentioned sertraline before, but also duloxetine and fluvoxamine. Duloxetine is actually a serotonin norepinephrine reuptake inhibitor, so it's not technically an SSRI, but it's because of its high serotonergic activity, can also do that. Some medications, like let's say Prozac, has a week-long extended release formulation, can be helpful. Effexor has an immediate release and extended release formulation, which is venlafaxine, that could be helpful. For those who are taking fluoxetine, even though fluoxetine or Prozac is helpful and has an FDA indication for bulimia, for anorexia, fluoxetines can sometimes decrease appetite in some kids. So if they're having a decrease in appetite or not eating as much and they're on fluoxetine, that's a known side effect specific for fluoxetine that they can switch. And the last SSRI specific known GI side effect is constipation, especially with paroxetine, which is Paxil. Paxil has the most anticholinergic activity out of the other SSRIs, so moving on from paroxetine to another SSRI would be helpful if they're experiencing severe constipation. There's a lot of symptomatic treatment that, especially in the first 7 days, that can be conducted. Adding milk of magnesia, reducing caffeine intake for teenagers can be helpful. Loperamide can be helpful for diarrhea. For nausea, adding ondansetron and metoclopramide. can be helpful. And for constipation, for most of them, adding fiber and increasing fluids can be helpful, although sometimes Decosate is needed. I will say that a lot of high schoolers are drinking way more caffeine than we did when they were their age. The rates of energy drinks and highly caffeinated beverage or coffees or frappuccinos or whatever Wawa or Dunkin' Donuts or Starbucks is giving is on the rise. So if you have people coming in with GI side effects, please ask about their caffeine intake because the rates of excessive caffeine intake is increasing. So dry mouth is something that has caused a few of the patients that I've worked with to stop the SSRI, in part because it's hard for them to speak, it becomes annoying, and I've had some adults that have been on SSRIs for a long period of times where their mouth got so dry that it caused dental issues. So it's more rare, but the best thing for it is using sugar-free gum or sugar-free candy that stimulates the salivary glands enough to help with dry mouth, cool drinks, frequent brushing. Um, there is OGT sprays that people have given that has helped, or even pilocarpine 1% solution. That's rare. I have done it a few times, but that's if this is the only SSRI that's effective and the dry mouth is really impairing it. Diaphoresis management is also something that's less common, but when people experience it, it does often lead to discontinuation of the medication. So it's rare, but when it does happen, it can lead to SSRI discontinuation, just like with sexual side effects. So a lot of times, antiperspirant or lowering the dose of the SSRI is the most effective. And diaphoresis, I can't find the data to say which SSRIs are least likely to cause it or more likely to cause it, but a lot of times the switching to another SSRI can help with diaphoresis, even if it's the same, roughly the equivalent dose. A lot of these medications for diaphoresis is individually specific. We don't know why one kid responds differently in terms of side effects to the same medication as another kid. So from a um, at a population level, we don't know which SSRI quite yet is more likely to lead to diaphoresis, but on an individual level, one SSRI is more likely to cause diaphoresis. Um, if it's very severe, you can take glycopyrrolate, which doesn't cross the blood-brain barrier, and oxybutynin can also be helpful for this. This is again when they absolutely need to be on the SSRI and they're still complaining of sweats. I've worked with some PCPs who have their kids being managed by a psychiatrist, but they're showing up to the PCP with these side effects. And these are things that can be helpful. But a lot of times, just even avoiding excessive sun exposure could be helpful. So this is some of the same things that we discussed with behavioral side effects, especially in the younger kids. This is hyperactivity, disinhibition. A lot of times just switching is the most helpful. So behavioral activation is often medication specific. It's not class specific. So with kids who becoming more agitated, more hyperactive on, let's say, fluoxetine, you can switch to something like sertraline and not experience those same side effects. If it's more mild to moderate, just even decreasing the dose by 25% could be helpful. So this is something um, that's a little bit different when we start talking about mania. Mania is something where there's 5 to 7 days of not sleeping, grandiosity, doing new activities they've never done before, having pressured speech. It can happen if you give an SSRI to a kid with bipolar depression. And what's hard in teenagers is in older adolescents, I meant older than 15 years old. Um, if there's a family history of bipolar and someone's presenting you with depression and you start an SSRI, in rare cases, you can elicit a manic episode. And if that happens, please stop the SSRI. They should only be on an SSRI if there's a mood stabilizer on board. Now, the odds ratios of switching that can differ, with sertraline being the most activating. And just in general, even though there's differences in activation, that's individual specific, at the population level, sertraline is slightly more likely to do it, and citalopram's the least. That said, these odd ratios are very close together, and there's debate about whether this is statistically significant or not. But I just wanted to present you to the data to show that if there's anything that we can gather from population level data, it's that sertraline is slightly the most activating, and fluoxetine is the second most, with citalopram, which is Celexa, being the least. Now, there are some things that if people are becoming a little bit more agitated with it, but otherwise their anxiety and depression's improving on it, some ways that you could do is switching it to an extended release formulations, lowering the dose, taking it slow, and doing split dosing as well. The only medication that sometimes can cause sleep, and usually it's not recommended to take it at night, is fluoxetine. The other SSRIs can be given at night or in the morning. And even in rare cases, fluoxetine can be given at night. It's just sometimes if you give it at night, it's the only one that can sometimes hurt with sleep. As I said before, with if it's just passive thoughts of death that have already been there before, it should go away as the underlying condition goes away. But if it's something that's new, or if it's something that gets to the point of self-harm behaviors, even scratching, increase in intensity of suicidal thoughts, increase in frequency, that's a cue to stop the medication and try a different one. For other side effects, if there's concern of headaches, it's very dose dependent. You can lower the dose or switch to another SSRI. And sometimes for the tremors, which is very rare, you can add propranolol as well. This is another for orthostatic hypotension. Please increase hydration, increase sodium in the diet, and just wait 30 seconds before walking and sit for 60 seconds if feeling lightheaded. Yohimbine is sometimes rare if they need to be on this SSRI and they're experiencing this side effect, but most of this is supportive interventions. So the other thing that, especially with adolescents, they ask a lot about weight impacts. Most of them have mild weight impacts. The one big exception for weight impacts is Paxil or paroxetine. Paxil paroxetine is the only SSRI that can really dramatically increase weight, and that's more than 5 to 10 pounds. The one that's least likely to cause weight gain is fluoxetine. And sometimes it can even cause weight loss. As I mentioned, that if someone's developing anorexia or appetite suppression and they're on fluoxetine to come off of it, well, on the flip side, fluoxetine is less likely to cause weight gain. So if someone's really concerned about weight gain, um, fluoxetine could be a better option. And that's something else to just make sure you ask the adolescents because they're not going to volunteer it. Please ask them specifically for it. So that's kind of what we have for today.